Hello, everyone. My name is Alex Milesevic, and I'm the Clinical Sales Manager with C-RAD. Welcome to our Clinical Education webcast. Today, we are excited to further expand our SGRT education series by welcoming Rebecca Edwards and Luis Muñoz. Rebecca is a radiation therapist unit manager for GenesisCare in South Australia. She has been working in radiation therapy for 8 years and has a Master of Business Administration from the University of Adelaide. Her areas of interest include utilizing technology and exploring new techniques to improve treatment outcomes and the patient experience, as well as optimizing workflows to benefit operational performance. Lewis works as a medical physicist for GenesisCare in Adelaide. Aside from his role within the clinic, Lewis is completing a part-time PhD through the University of Wollongong, with an interest in small field dosimetry and planning automation. Over the past years, Rebecca and Lewis have led the commissioning and clinical implementation of C-RAD systems at their respective departments. They are seasoned users of C-RAD technology and adopted advanced treatment routines. Together, they will share experiences from the GenesisCare group and provide practical advice to elevate your own clinical routines with the help of surface scanning technology. Before I hand it over to Rebecca to begin today's session, I would like to cover some quick information about today's webinar. This session is being recorded. You will receive a link to the presentation via email, and it will also be available on the C-RAD website if you would like to review it at a later time or share it with a colleague who wasn't able to join us today. If you have any questions during the presentation, please go ahead and enter them at any time using the Q&A function. I will moderate those questions after the two presentations. The presentations are approximately 40 minutes with Q&A at the end. If you have trouble hearing, adjust your volume. If that does not help, try signing out and back in again. Thank you for your attention. Now I'll hand it over to Rebecca.
Thanks, Alex. So my name is Rebecca Edwards. I'm a radiation therapist unit leader from GenesisCare in South Australia. And today I'll be sharing my insights from my team's experience with implementing C-RAD SGRT technology for breast cancer patients at one of our clinics in South Australia. I will specifically highlight how the implementation process affected patients' average treatment times and overall operational efficiency. So a background of C-RAD and SGRT in general for those who may be new to the technology. So one of the key benefits is that it allows for a tattoo-less workflow. So this means that patients don't have to undergo any permanent skin markings, which not only reduces anxiety, but also eliminates any long-term reminders of their treatment. This is something we've seen patients appreciate, as it helps make the entire process more comfortable and less invasive. It also enables more accurate real-time tracking of the patient's surface during treatment. This level of precision is critical, allowing us to adjust for even the slightest movement and ensure the radiation is delivered to the exact target. Another exciting aspect is the breath-held technology offered with C-RAD. Unlike traditional methods that focus on a specific lung volume, this technology works directly on the patient's external surface, making the process non-invasive and more intuitive. In fact, patients often find the natural breath-hold technique much more comfortable, with many reporting that it feels more natural than other methods. In addition, the C-RAD integrated light panels, shown in this picture here, provide a visual cue for patients, letting them know when they're in the correct level of breath hold. This feedback not only empowers the patient, but also helps us maintain the precision required for optimal outcomes. So a background to GenesisCare in South Australia and the implementation of C-RAD. So in South Australia, GenesisCare has 4 sites that offer radiation therapy treatment. SGRT technology was first installed at our Flinders Private Hospital site in March of 2023, and this was shortly followed by our Central South Terrace site in July of the same year. At this time, patients were still given tattoos or non-permanent Beakley markers at CT, while staff familiarised themselves with the technology and gained confidence with the system. We also limited the patient cohort we were treating with SGRT to breast patients, both breath hold and non-breath hold. However, we now treat a variety of treatment areas, including chest and abdomen, and are also in the process of rolling out SGRT for brain patients using a faceless mask system, SRS, and Sabre prostate. A select group of staff were vendor trained by C-RAD application specialists in the days before going live with technology, and this formed the local subject matter expert group, who would then go on to develop and co-author work instructions and credentialing frameworks following the guideline and recommendations of our colleagues at GenesisCare in WA, who had preceded us with the SGRT implementation. So the motivation for my particular research project, personally, I have just completed my Masters of Business Administration, and I have a strong interest in technology and its utilisation to improve processes and workflows. From an organisational point of view, so the most treated tumour stream is currently breast, and for comparison, the next most treated tumour stream is prostate, comprising 18%, and bone and soft tissue at 12%. We had multiple C-RAD systems being installed at GenesisCare sites in South Australia, with the operational goal being to reduce breast treatment times at C-RAD equipped sites to what they were before implementation. So in terms of the business problem, with any new technology, radiotherapy aims to enhance patient outcomes and improve the experience. However, there can be the operational issue that the initial implementation can lead to increased average treatment times and reduced machine utilisation. And this is something the business must consider. And this delay is attributed to several factors, including the need for staff to gain confidence and proficiency with the new system, as well as the existing workflow processes not being fully optimised to accommodate the technological advancements. So the key challenges, firstly, being the extended treatment duration. So longer sessions are required due to staff learning curves and training requirements. Additional time is also required for proficiency with the new system, and existing workflows are not optimized for the new technology. This has a flow-on effect which can impact the business. So the increase in treatment time and reduced operational efficiency has the potential to lead to extended patient treatment times, which can adversely affect the patient satisfaction and outcomes, reduced throughput, impacting the facility's ability to handle the same volume of patients as before, and therefore the potential to increase operational costs associated with longer treatment sessions and the potential for needing more staff. To address these challenges and minimise the operational impact on the organisation, it was crucial to develop and implement a strategic plan that included comprehensive staff training, a review and redesign of workflow processes, and ongoing assessment of the new technology, impact on operational efficiency. The goal was to mitigate the initial inefficiencies and really fully realise the potential benefits that the technology has to offer in improving patient care and overall treatment effectiveness. So in terms of the results, for this particular study, the data was collected retrospectively using a Tableau dashboard system available to all GenesisCare staff. The dashboard automatically collates data from Mosaic and groups it accordingly. For this study, patients' average treatment time was used to make deductions on whether efficiency increased or decreased over the implementation period, which ran from August of 2023 to February of 2024. For the SGRT-only cohort without breath hold, the implementation of SGRT at Clinic 1 resulted in an initial increase in average treatment time when compared to pre-implementation and to Clinics 2 and 3, and this was hypothesised. After the first month of implementation, the average treatment time was sitting higher at around 16.5 minutes, compared with 12 and 14 minutes at Clinics 2 and 3 without SGRT. However, as clinicians became more familiar with the technology over time, there was a noticeable decline in average treatment time and therefore an improvement of operational efficiency over the data collection period. At the end of the study, the average treatment time was approximately 11 minutes for the SGRT-only cohort. This is a significant reduction of 5.4 minutes in treatment time when compared to the non-SGRT cohorts, with the SGRT clinic demonstrating better efficiency with an average treatment time 1.9 minutes faster than Clinics 2 and 3. Similar to the results observed for the SGRT-only cohort, there is a downward trend observed in the average treatment time for the breath hold cohort. At the end of the first month of implementation, the average treatment time was sitting at 20.5 minutes for this group. The average treatment time for the breath hold patients treated at Clinics 2 and 3, respectively, over the data collection period was consistent at 16 and 17 minutes. At the end of the study, the average treatment time was approximately 14 minutes for the SGRT-equipped clinic, and this is a 6.4 minute reduction in treatment time over the 6-month period. At the conclusion of the study, when compared to the non-SGRT cohorts for breath hold treatment, the SGRT clinic demonstrated a lower average treatment time by 2.4 minutes. So during the vendor training offered by C-RAD, there were several options introduced to the team to help patients with their breath hold coaching. Firstly, a visual coaching tablet, which sits above the patient's face for the duration of treatment and provides real-time feedback on their breath hold. Secondly, there are the in-room light panels, which change colours depending on the breath hold amount. And lastly, the several monitors that sit in the treatment console that only the radiation therapist can monitor, which shows the patient's external surface at all times as it relates to their original planned scan, the isocenter tolerance by measurement, which we have in millimeters, and the same gating box system, which the patient can see. On the 23rd of October, 2023, the team decided to move towards an RT-guided approach for breath hold and remove the visual coaching tablet from the patient's view. At this point, depicted by that star on the graph, efficiency was further enhanced, as is evident by the greater reduction in average treatment time when compared with the SGRT-only cohort. The steeper decline in average treatment time noted after this date cannot be completely attributed to further workflow confidence, as this trend is not observed for the SGRT-only cohort, where the average treatment time reduction plateaus after this day. Therefore, we can conclude that the removal of the visual coaching tablet and adoption of the new coaching system, so voice coaching with secondary visual light coaching, resulted in further improvements to efficiency at our clinic. So what could the reasons be for improved operational efficiency with C-RAD? Firstly, there was a noticeable reduction in the manual handling of patients. Staff noticed that they were having to roll patients less to achieve the correct chest rotation, with only minimal movements of the patient's hips, shoulders, and arms being required to achieve a desired position. Streamlining patient handling processes minimizes the physical effort required from staff and has multiple benefits. It has the potential to reduce the risk of staff injury, improve patient comfort and safety by minimizing unnecessary movement, and allows radiation therapists more time to focus on other critical tasks, enhancing overall workflow. There was also improved accuracy in complex patient positioning. So for example, in GenesisCare in South Australia, our doctors request for breast and nodes patients that the patient's head be turned to the side and the chin extended. So instead of using the ruler to measure this position as traditionally done, with C-RAD, you can actually see a 3D render of the patient's head, neck, and chin, allowing for a more precise setup. This ensures correct treatment delivery, leading to better patient outcomes, and reduces the likelihood of errors due to improper positioning. It increases staff confidence and decreases the time spent on readjusting the patient during the procedure. Staff also noted patients were able to hold their breath significantly longer without the need for a verbal countdown, and that their breath hold improved over the duration of their treatment course. This had the potential to reduce patient treatment times as fewer breath holds are required. It reduces treatment interruptions, enabling more seamless and efficient procedures. There was also a noticeable reduction in repeat cone beam CTs and repeat positioning. With the enhanced accuracy of the initial setup in the room with better positioning, the result was that there were fewer instances where rescans were necessary. This saves time for both staff and patients by reducing the need for repeat procedures and improves patient satisfaction due to fewer disruptions and shorter treatment durations. So our recommendations would be to anyone looking to implement C-RAD technology in the near future to have a robust competency framework in place and to have a plan to build team competence. Secondly, it is important to have detailed and up-to-date work instructions and a recommended workflow so that anyone going through the training process can refer to these at all times. We used consistent tracking of efficiency data, especially for this study. So I utilised average treatment time, but you can also utilise wait time and utilisation. We decided to move towards the RT-guided approach to breath hold, which showed further efficiency gains at our clinic. And having more in-depth breathing and coaching instructions at our CT appointment proved very beneficial. We had regular meetings. So in South Australia, we would have fortnightly meetings with the local subject matter expert team. We also had meetings nationally with a variety of stakeholders, being physicists, engineers, our project manager, C-RAD application specialists, and our radiation therapist counterparts in WA and New South Wales, This way we could integrate information and tell each other what was working and what wasn't, and help each other to resolve issues quickly. We've developed a number of decision trees for problem solving in complex cases that staff could follow during the training process. At South Australia, we follow a lean in-room workflow, which means one RT is standing on one side of the bed. They're in charge of operating the C-RAD technology at the computer, while the opposite radiation therapist stands at the patient's side, adjusting their position as indicated by the first radiation therapist. This meant that everyone had their role before entering the room, and we were limiting movement across each other. So the results of this study can be used as a guide for clinics looking to implement C-RAD technology in the future, and be confident that it is possible to have similar, if not improved, operational efficiency outputs with this technology. It is also important to note the additional benefits this technology offers, which includes a superior patient experience. Patients at our clinics have stated that the natural breath hold option available with C-RAD is much preferred over the traditional snorkel-based system and helps reduce their anxiety. They also noted the light coaching system makes them feel in control during their treatments, and the ability to move to a completely tattoo-less approach is also a key benefit that can't be ignored. So thank you, and I will now hand over to Lewis to share his presentation.
Cheers, Rebecca. Thanks for that. So yes, my name is Muñoz. I work as a certified physicist for Genesis in South Australia, and today I'll be presenting on the integration of C-RAD with complex treatments. I'll try and make it as practical as possible. So GenesisCare operates C-RAD across multiple states, including South Australia here. We have an ever-growing footprint of our C-RAD installations as well, where we use the Catalyst Plus HD version 6.5. At our sites, we either have a combination of the Catalyst with the Sentinel, or the Catalyst alone with simulation workflows for our DRBH processes. We utilize the ceiling light panels as detailed by Beck, and coaching tablets are also available for use. And we are licensed for SRS. And in practice, what this looks like within the bunker, don't mind the holes in the ceiling here. This was during commissioning, so they've all been shored up. But yeah, we have 3 cameras that are suspended from the ceiling with the light panels up there in the ceiling as well, and a single workstation here where we've consolidated with our iGuide on the Electa platform here. And in the console area, we just see the single screen alongside our cameras for patient monitoring. So the C-RAD system is integrated easily into our existing room and console setup. And so what are the benefits of SGRT? Just to add on to what Beck has already described, and it pairs well with this article here by Al Halak. It's quick and efficient for patient setup. It's versatile across multiple sites. You're using a non-ionizing imaging modality for continuous 3D assessment. And one of the specific pros that we were after within GenesisCare was its use for SRS, so that's sub-millimeter accuracy. And addition to this, we can utilize SGRT as a means to check for things like bolus or other positioning equipment that is used for patient treatment. Cons, there isn't a perfect solution, but we can always work and move towards a perfect solution. But we cannot truly correlate the internal movement with the external monitoring. So we still utilize cone beam CT as a means for patient positioning as our primary method. The system itself can suffer from accuracy issues with darker skin patients. And the simple fact that you're adding another system to your workflow introduces a new failure mode that you need to account for. And then one of the pinch points for the C-RAD system in the Electa space is its lack of integration with the hexapod. So you don't necessarily get that 6DoF correction from the C-RAD system, but we've made ways to work around that situation in GenesisCare. So the case study for SRS. Whole brain radiation therapy is a mainstay treatment for patients with both identifiable brain mets and prophylaxis for microscopic disease. But as patients' life expectancy increases, consideration of quality of life in favor of focalized treatments like SRS, when compared to whole brain radiation therapy, is becoming more important. So with SRS, we have a variety of different specialized equipment where we can deliver said treatment, but the practicality of a LINAC, which is a veritable Swiss Army knife, it does complex treatments, it does your conventional treatments. It's we love the LINAC within the GenesisCare network, just because it gives us the ability to do so many things with it. So integrating C-RAD with on a LINAC platform makes so much sense. And those dependencies that SRS requires us as physicists to make sure that immobilization, image guidance, and precision delivery is paramount to patient safety and delivering on the RO's clinical intent. So from technical priorities from a stereo program, physicists are always trying to reduce the uncertainty in the constituent parts of a treatment workflow. So imaging, patient positioning, immobilization, and motion management on the LINAC itself, treatment accuracy, and routine QA. So we're always trying to account for dosimetric inaccuracies at the point of commissioning and acceptance, and also reducing the possibility of geometric miss. So as we move away from isocenter, we want to make sure that we have that fidelity geometrically and dosimetrically. So we use a number of different specialized equipment that include high resolution detectors, both planar and point, to make sure that we're assessing the LINAC's performance against the treatment planning system. And that brings us to assessment of beam models and the like. So we have a broad number of checks and validations within the treatment chain to make sure that we are delivering what we are intending from the treatment planning system. So that would also include mechanical isocenter and the isocenters of, say, your gantry, your collimator, your couch, and making sure that your quality assurance programs adhere to those strict tolerances to make sure that you are delivering safe and effective treatment. In addition to this, we utilize multiple detectors in an end-to-end fashion within QA phantoms as well, anthropomorphic and heterogeneous, to make sure that we are being as comprehensive as possible. So with respect to the C-RAD system, we in this image here, we get those color projections on the patient, where if the patient's position is superior to the anterior to the reference position, we get a red image. If posterior, we get a yellow image. So it's a really straightforward and easy way where you get that structured light that's being delivered by each of those cameras on that patient to as a visual cue where a reposition is required. With respect to the plus HD SRS mode, the patient surfaces are captured with higher resolution, and the point cloud used to assess the patient's position is increased. So you get a camera exposure that is a lot higher, and a semi-rigid algorithm that's used. It's like a semi-deformable algorithm that's used to accommodate for natural movements like grimaces or breathing and eye blinking. So the background performance of the system in a HD SRS mode, the performances that we've validated during our acceptance and commissioning is long-term stability within 0.3 of a mil, reproducibility within 0.2, position accuracy within half a mil with a rigid body, and motion detection accuracy within 0.5 when a rigid body is fixed in position. And we've been able to validate and correlate these across these accurate performances across multiple LINACs within our network, where we share a commissioning spreadsheet across multiple different vendors, say AlignRT and ExactTrack, Dynamic. So there are also a number of articles that have been published reporting on the performance of the C-RAD system. One to note is one published by a couple of physicists that work within the Genesis network on the accuracy performance of the Catalyst system. And I just wanted to draw your attention to some of the results and urge you to have a look at it. So here we have a number of plans with varying PTV volumes, also on axis and off axis up to 7 centimeters at numerous couch rotation angles, with performance of a gamma analysis using the SRS map check to be well within tolerance for 3% 1 mil. Yeah, so I think that this is a fantastic piece of literature that you can have a look at to verify its performance. And I guess looking towards how we set up our LINACs with regard to considerations for SRS, a lot of the TPS, the QA that we perform on our LINACs is effectively more stringent because we want to be able to have all of our LINACs perform at the same level. So having a matched LINAC approach to make sure that our mechanical and dosimetric performance amongst our LINACs remains at a high quality. So with regard to the practicalities of SRS QA within the C-RAD space, the daily QA and also the QA required to put the LINAC with the C-RAD system within the SRS mode, recommendations towards a high quality CT of your pentaguide really necessitates, I guess, the ability to have a high quality image to work from for precise positioning of your ISO center. From the point of designating your ISO within the TPS, this also helps. So, and accurate contouring. With respect to LINAC QA, so the C-RAD system in of itself is fantastic, but it's only as good as your LINAC QA is. So if you have poor LINAC QA with loose tolerances, setting your C-RAD system up in this regard is not going to bode well for its performance. So centering of your MV beams with half beam blocks validated with Winston-Lutz tests. On the Elector side, having flex maps that are good quality, aligning your KV and MV ISO centers, the validation of the quality of your flex maps with the use of the ball bearing phantom, and having a good quality flex map also ensures accurate cone beam CT image reconstruction. So this is a very important part of your QA processes. In addition to this couch QA, we've instituted a spreadsheet to ensure that we can monitor the QA of our couches at the most extreme angles of 90 and 270, just to make sure that we have a robust mechanical assessment to reduce that couch walkout. And again, utilizing the ball bearing phantom as a means to validate that from a radiation perspective as well. So with respect to our commissioning and routine QA, we've referenced AAPM report 302 and also the ACROP SGRT guidelines. At the point of commissioning, making sure that data transfer and integrity is good, coordinate system validation, your beam hold trigger, couch shifts, all within a mil, and system drift and isocenter coincidence within the established tolerances. And again, an end-to-end process with rigorous testing using anthropomorphic phantoms is really going to get you over the line. So of the, I guess, the pinch points with the C-RAD system, the lack of communication with the hexapod couch has been a point of contention and also a point of conversation with C-RAD. So in the interim, we utilize a couch correction calculator where we utilize the iGuide system and reduce our roll, pitch, and yaw from the hexapod couch into a translation. So for non-couch zero adjustments, where C-RAD details a greater than half a degree rotation, we apply translations to correct for those rotations. And so we have specific couch calculators that are characterized on the Linux that are being used. And we use that MVKV coincidence results to reference at couch zero so that we are adequately achieving those rotations with translations. With respect to C-RAD calibration tips and tricks, we want to make sure that we're always careful not to bump the cameras. They're very sensitive, and making sure that they are protected in as much as from random hits. You see any minor shift of the camera will be emphasized at isocenter. Making sure that your cameras are up to temperature is also very important. And once you are going through the process of calibration, that calibration board that comes with your system needs to be well cared for, because any damage to that will invalidate your OBC file. During camera characterization, using a jig to make sure that your calibration board is still, and making sure that at those 45, 50, and 15 and 30 degree and 90 degree acquisitions are done as comprehensively as possible, and making sure that your EOR results from your calibration are less than 0.2 of a mil. So I guess when there are camera specific performance issues, I think that that's you're well in your right to talk to C-RAD about that if you have performance issues. Characterizing the cameras for fault finding is also something that could help with assessing whether or not you have a poor performing camera to then feed back to the vendor. And covering camera lights in turn, observing your Pentaguide Phantom C-RAD results to help to identify any poor performing cameras. And we've set a threshold of any deviation greater than 0.5 as a means to either recalibrate and then if we're not able to resolve, escalate to C-RAD. So with respect to our TPS workflow, pre-simulation, we assess the hexapod suitability, so evaluating the hexapod frame over our patient anatomy, making sure that it fits, and determine if it allows for positional corrections during treatment. With regards to CT data preparation, practically speaking, what we do, we send our surface guidance, SGRT surface generated within MIM, and verify the surface contour accuracy for treatment planning. Once we have our data prepared in MIM, it's exported to the Monaco treatment planning system, where we don't necessarily have any exclusion zones or exclusion couch angles. So all of our plans are generated with the aim to optimize collimator, isocenter position, and couch kick. For single and multi-met cases, we validate and export the exported plans against the catalyst import parameters, ensuring the alignment with the SGRT service and treatment type, and perform any physics QA. Beyond that, considerations on the Catalyst Plus integration, the bounding boxes, making sure that they cover the region of interest, and ensuring our tolerances are set. In practically speaking, we also make sure that those gantry and couch rotations account for any potential gantry obstructions in the Catalyst Plus monitoring system when planning those beam angles, though. And then physics QA is performed using the SRS map check with a custom created 3D printed Phantom with tolerances of 95 greater, passing 3% 1 mil at 10% threshold. And these are done without completing that shift that's allowed within the S&C software. So from a immobilization point of view, we utilize the Clarity Open Face Mask, and during the treatment process, we assess for any pitch, roll, or rotational deviation at couch zero using the hexapod, and then only perform that translation correction at non-zero couch with C-RAD using the hexapod itself. So from a workflow perspective, we have the patient set up, complete the cone beam CT, apply those hexapod corrections, and then acquire that C-motion reference image. From there, we repeat and then retract our panels and XVI tube, and then acquire that new C-motion reference image that's been validated with that cone beam, and then deliver treatments where we have to be within that 0.5 mil and 0.5 degrees during that a non-coplanar delivery. And then again, as detailed, if we have any rotational errors greater than 0.5, we do that translation using that couch calculator. So I guess with respect to best practices and lessons learned for that SRS implementation, which offers I guess a challenge, and not just to the physics group, but to the entire team. Like we always have to consider the all craft groups that are working towards delivering quality and safety to our patients. So during our rollout of SRS, having those weekly meetings, or at least when you have that sense of confidence, changing the cadence to say fortnightly with the ability to evaluate methods. We find bottlenecks, as a team work on troubleshooting, and then with the aim of creating uniform workflows. One of the things that we definitely did across all of our sites within the C-RAD system is to consolidate to a single set of tolerance tables, which really helps make things uniform. And again, using common commissioning and QA workflows will definitely help from I guess a multi-user site perspective. Having procedure manuals that are common, and also utilizing SWOT analysis to find strengths, weaknesses, opportunities, and threats within specific complex treatments, workflows. And then again, training, credentialing, and mentoring is definitely something that will always continue to make things more robust and resolve any issues in a quick and meaningful manner. So I think that's my time. So I'd just like to hand over to Alex.
Thank you very much, both Rebecca and Lewis. Those are very thoughtful and fascinating presentations. Our audience has been quite engaged, and we have received a few questions for you. Just a reminder for the audience that there's still time to enter your questions in the Q&A session. That's the button on the bottom of your screen, should you still have questions for our two speakers. If you and Rebecca are ready, then let's jump in to the questions. First question I have here from Sophia for Rebecca. Rebecca, do you use the hexapod with Catalyst, and what indication do you use it for? You use it for SGRT, DIBH, both?
In South Australia, our doctors actually prefer to use an angled breastboard. So we did try to use the hexapod, but unfortunately the frame doesn't fit in this instance. So you would have to move towards a wingboard approach for breast treatments, which I know our counterparts in Australia and GenesisCare do. So I know it is possible. We don't unfortunately use hexapod for breast treatments at this stage. We will be using it for our faceless head and neck and brain treatments, and Lewis said, our SRS. So we will utilize it alongside SGRT. As like Lewis said, there's obviously the introduction of a different type of technology. So there may be those failure safes or little risk factors that can pop up having two different types of technology. But as long as you have a team that's able to handle that and are trained and credentialed appropriately, it should be no issue.
I have a question for you, Lewis. How often do you perform Winston LUTs?
So at the moment, we complete it on a monthly basis. So we did have a more frequent cadence when we started our SRS program. But once we had a confidence in the performance of our Winston LUTs, yeah, we were able to reduce the cadence down to a monthly basis.
Thank you, Lewis. And staying with you for a moment there, there was a question regarding the hexapod frame. Do you remove that after cone beam, or do you keep it on, and does it interfere with C-RAD's cameras?
No, no. So we keep it on during the entire treatment because we use the eye guide as a means to validate our couch rotations. So that the hexapod frame doesn't occlude the cameras during treatment, which is good as long as the reference frame is within, I believe it was 1 meter of the isocenter. That is yeah, satisfactory from an eye guide perspective, but we haven't had any issues as of yet with the position of the reference frame interfering with the C-RAD system.
Thank you, Lewis. Let's go back to Rebecca. I have here a question from Eric about repeat cone beams. Eric does not have SGRT in his department, so he's wondering for which categories do you see more frequent repeat cone beams, Rebecca, and
I
which
guess,
indications
yeah.
benefit them?
I think with our breast patients, traditionally, we did see that sometimes on our cone beam CT, because it's so accurate these days, we could potentially move the patient's hips to achieve a better symmetry with the bones and the soft tissue, or that their arm clavicle position could move up or down and their head turned more to achieve a better position. And we do try and go back in the room and correct this before we treat. However, with C-RAD, we're noticing that the images, we're agreeing with them a lot more between the radiation therapists, and they're much more aligned to the original planning scan. Our isocenter shifts are usually under 0.5 centimetre, if not just 1 or 2 mils. So we're just finding that C-RAD's enabling us to get more accurate images more quickly.
Thank you. I think you addressed this, but then let's double check. When you position patients for the IBH, do you use an angled breastboard? I think you mentioned a wing step.
Yes, we use an angled breastboard primarily because that's what our doctors want to do. I think it's because it helps to bring the breast tissue fall away naturally from the neck and kind of chin area, so that we're able to achieve the tolerances that our doctors ask. But we are in the process of looking towards a more wingboard like treatment aid for patients. So in the future, we will be able to use hexapod for breast treatments. And I know, yeah, GenesisCare sites in Australia are already doing this.
Staying on the topic of the IBH, and I think this is one of the last questions. Rebecca, how long approximately are patients holding their breath during a breath hold treatment?
Yeah. So traditionally, when we were using the snorkel-based system, we would have a 30-second tolerance for breath hold, and then we would ask the patient to breathe out. However, with, yeah, as I mentioned, with C-RAD, we're seeing much longer breath holds. I think yesterday I treated a patient and she held the full 800 monitor units, which is like almost 2 minutes, which is crazy. But I think because patients have that visual cue of the green lights and our visual voice coaching, they feel much more comfortable holding their breath, knowing that they're in control and they can let go anytime and the machine will automatically switch off. So yeah, some patients are doing it in 1 or 2 breaths compared to 5 or 6 that we were traditionally seeing.
Well, we're at time. So at this point, I'd just like to thank you both, Rebecca and Louis, for the discussion and also our audience for sharing their questions and showing their interest. Thank you, everybody. If we didn't get to your question, we will reach out to you after the broadcast. And as a reminder, we will be sharing the link to the recording with all attendees later this week or early next week. With that, I will close the webinar for today. Thank you all and have a wonderful day. Bye.